Okay, hello everyone. Very glad to give the uh, lecture. And in this lecture, I will introduce some techniques I invented in the past decade. And this is my hospital, and these are the staff of my cardiovascular department. And the first technique I invented about 10 years ago is the seesaw blown wire cutting technique. As we know, uh, at present in China, there are more than 1.3 million PCI cases, and more than 19% was performed via trans-radio approach. But in the past, because of the glide siege, so for the trans-radio approach for the CTO PCI, we often use the sixth branch guiding, and we often meet the condition when the CTO wire crossed the CTO lesion, but the balloon and other device couldn't cross, just like in this case. This case is RC CTO with severe calcification. And after the wire crossed the CTO lesion, but the smallest balloon couldn't cross, even exchange new balloon. And the tonus catheter also could not cross. And for this kind of condition, I invented the technique. I call it seesaw blown wire cutting technique. That means when one wire crosses the CTO lesion to the distal vessel lumen, and another wire was advanced along the first wire with the help of the microcatheter, and then two small profile balloon was advanced. And at first, one small balloon was advanced as distal as possible and inflated. And the balloon will cross the body wire cause balloon wire cutting effect in the fibrotic cap. And then we withdraw the first balloon and advance the next balloon as distal as possible and inflate again. And then the two balloons was advanced alternatively and finally recanalize the CTO lesion. Just like in this case, we can see balloon A and balloon B was advanced alternatively, and finally one balloon cross, and this RC-CTO was finally successfully recanalized. And we published our initial experience in the Journal of Invasive Cardiology, and the success rate is 81% for the blown uncrossable CTO lesion. And we also compared the seesaw blown wire cutting technique and the tonus catheter technique. And we can see the procedure success rate in the tonus group is 72.5%. But in the seesaw blown wire cutting group, the success rate is more than 19%. And also in a few cases, we can see this is a circ CTO case. The smallest burr couldn't cross the circ CTO. And finally, we use the seesaw blown wire cutting technique and successfully recanalized the circ CTO. And this technique very suitable for when the vessel with anomalous outcome of, and when the guiding couldn't provide enough backup support, just like this RCA CTO lesion. And also we finally use the BL30 7 French guiding, use the balloon ankle technique, but we can see the smallest balloon could not cross. And after use the seesaw blown wire cutting technique, the RC was successfully recanalized. Let's see the first case for the seesaw blown wire cutting technique I did about 10 years ago. That is a RCA CTO lesion, also with the LED CTO lesion. This is a VIP patient. And this is the first case I use the seesaw blown wire cutting technique to recanalize the CTO lesion. And 9 years later, the patient was readmitted again with atrial fibrillation, and we did coronary angiogram. We can see the RC is quite good. And this technique was enrolled in the Manual of CTO Intervention, this book. And this is the chief editor of this book, we meet in the Sky meeting, and I already translate this book into Chinese edition. And the next technique, I call it ankle-knuckle technique. This technique is used suitable for the long instant occlusion case. That means because also for the instant occlusion case, the stent could be used as a landmark for the wear advancing, but sometimes the plaque is very stiff, and especially for the very tortuous vessel, sometimes the wear may go outside the stent strut. And the ankle-knuckle technique means use OTW balloon to do a coaxial ankle to provide enough support, and then use the knuckle wear to cross the instant CTO lesion quickly. And certainly, firstly, we should use dedicated CTO wear to come into the instant plaque, and then advance OTW balloon and inflate it, and then exchange the wear to do knuckle wear. And because there is stent outside, in such condition, we could use very stiff get wear like Pilot 200, even some dedicated CTO wear. And if the distal cap inside the stent, we could directly knuckle the wear to the distal lumen. But if the distal cap was located outside the stent, the knuckle wear should not advance to the distal to the edge of the stent. And at that site, we should exchange dedicated CTO wear and then manipulate the wear into the distal lumen, or use ADR or retrograde approach. Let's see a case. This case I did in the MedStream 360, the global live demonstration. This is a long instant occlusion case. We can see the stent from the proximal RCA to the distal RCA. And the first time PCI field, we can see the wear go outside the stent strut. And at first, when the wear was advanced to a side branch, and I try to make sure where is the ostim of the CTO lesion. And then the wear was advanced, just to use the stent as a landmark. But the IWAS showed the wear go outside of the vessel structure. So if we use balloon to dilate, very dangerous. So I use ankle-knuckle technique, and generally I will use 2.0 balloon to do inflation to provide enough backup support, and use Pilot 200 where we can see the wear could be advanced inside the stent. And then the 2.0 balloon was advanced because of the knuckle wear already make a channel, and the balloon was advanced further and inflate again and do knuckle again. And finally, the wear was advanced to the distal lumen and successfully recanalized the long segment CTO, and then use DB balloon. And these are some also use ankle-knuckle technique to recanalize the long instant CTO case. Next technique is the absorbable or silk suture embolization technique for the collateral channel perforation or small vessel perforation. I already use this technique for many years. Maybe some doctor like Professor Wu already familiar with this technique. Let's see, this is a two-segment RCCTO case. Distal cap is just at the distal bifurcation. And we use retrograde approach and use the atrial channel. And after the reverse cut technique, the wear was successfully externalized, and use Duramin catheter advance two wires to the distal RCA. And before we withdraw the 3-meter wire, and I withdraw the coaxial microcatheter and to check the collateral channel, we found the collateral channel already ruptured. So certainly we could use the coils to embolize, but the technique is use two fan cross microcatheter was advanced. We can see two macros from bidirection. The fan cross microcatheter was advanced to the collateral rupture please. And the silk suture, 3-0 silk suture was cut into small segment, like 8 to 10 millimeter. And the silk suture segment was pushed by the common workhorse wire from bidirection. You can see the wire push the silk suture segment. And then we straw the microcatheter a little bit and advance another silk suture. And generally, I will advance 3 silk suture segment in one direction. And this is from another direction to push the silk suture, and then check with the angle and the implant stent. This is the final result. We can see the RC was successfully recanalized, and the ruptured collateral channel was successfully sealed by the silk suture. And this technique also suitable for distal artery perforation. We can see this is a distal RCA vessel perforation already caused cardiac tamponade, and I use this technique and successfully sealed the large perforation. And the tips and tricks of this technique is to use fan cross microcatheter and 3-0 silk suture or observable suture. Observable suture, how to make the suture segment into the fan cross, we should tilt the distal end of the fan cross microcatheter and perfuse with C-line. And the observable silk suture, when we put inside, will sink down directly to the fan cross microcatheter, and the silk suture may floating inside the C-line, and we use the introducer to push and then advance the workhorse wire. And certainly for the collateral channel perforation, we should embolize from bilateral. And the advantages of this technique is high success rate, easy to operate, short preparation time, no immune reaction, or low cost. And also a very important thing is it is invisible. And another technique is the birescue technique. We all know that for the large vessel perforation, sometimes we have to use cover stent, but the cover stent is relatively expensive and not available in all the medical center. And the cover stent also with not very good prognosis may cause the thrombus or may cause restenosis. And especially like in this case, here with a very large diagonal branch, if you use the cover stent may cause large segment, large area myocardial infarction. So for this kind of LAD perforation case, how to treat? And I invent a technique, I call it birescue technique. That means the blown occlusion and the thrombus aspiration catheter mediated distal coronary perfusion technique. So I call it birescue. That means we use Duodenum catheter and one wire advance a balloon to seal the perforation site. And another guiding catheter advance a wire and use the thrombus aspiration catheter to the distal of the perforation site. And then use the balloon to seal the perforation and use the OTW chamber of the thrombus aspiration catheter to do distal perfusion. And we could occlude for very long time, and the patient will not have the ischemia symptom. And for this case, and we can see if you use the thrombus aspiration catheter, and we could inject the blood about 120 millimeter per minute. that is enough for the perfusion of the distal myocardium. And after almost 2 hours occlusion of the balloon, we can see the perforation was sealed and all the vessel is patent. And another technique is use mother-in-child catheter to aspirate the refractory thrombus. This technique already used more than 10 years. Let's see a case. This case is a thrombus embolization case after the proximal LAD stent implantation. We can see the thrombus formed in the guiding was taken to the left main and the proximal LAD. The patient is very dangerous. And for this kind of thrombus, the common thrombus aspiration catheter, no use. And then because of according to the Postulus law, the thrombus aspiration efficacy is positive, has positive correlation with the force power of the radius of the catheter. That means the aspiration rate of 5 French child catheter is about 3.5 times more than the common thrombus aspiration catheter. So I use the child catheter to aspirate the thrombus. We can see the thrombus in the proximal LAD and the left main disappear, but in the distal LAD still lots thrombus burden. And I use the thrombus tool to aspirate the distal vessel thrombus, but still couldn't be taken out because this thrombus is formed in the guiding, very difficult to be taken out. So how to treat? In such a condition, I want a technique called thrombus catheter mediated the twisting wire technique. That means the wire cross the thrombus, and then a thrombus aspiration catheter was advanced to the distal of the thrombus. Then a special shaped wire was advanced to the distal of the vessel, the wire with special shape. Commonly, we use the thin wire, and the wire was shaped into U curve first, and then make a perpendicular curve proximal to the first curve. And in such shape, the 2 wires could be twisted and in a very, very tight mode could catch the thrombus. And when we take out all the wires and the guiding catheter and advance look like this, and take out everything outside. And we advance another new guiding catheter again and do the angiogram. We can see the thrombus already been taken out. The effect like the solitary stent. Let's see another case. This is a circ after stent implantation, thrombus embolization, and certainly the common thrombus aspiration catheter no use. And we use our novel technique, the thrombus aspiration catheter assisted twisting wire technique, and take out the thrombus like that. Let's see a case. This is a LAD coronary heart disease patient with severe calcification. After root and stent implantation, after post-dilation, we can see vessel perforation. And we use the bi-rescue technique to seal the perforation. But after the perforation was sealed, we can see thrombus formed in the distal LAD. How to treat and use the thrombus aspiration catheter mediated twist wire technique. The thrombus was taken out. And this is the final result, quite good. And we also invent AI system. I call it Intelligent Visualization 3D CTA system. We can see this is the RC CTO, and this is the left coronary artery. We already implant stent in the LAD and the circ. This is a common CTA, but we couldn't make sure the distribution of the calcified and soft plaque in the CTO segment. But with the novel system, we can see the VSO and the delta in different color, and the imaging could be rotated in any direction. And we can see in the CTO segment, the brown one is the soft plaque, the white one is a calcified lesion. And we also could see very clear collateral channel, and we can see in the distal cap of the CTO, there is a severe calcified lesion. So this is a very important information, because at the distal cap, there is a calcified lesion, the wire may very easily to go outside, not come to the RC trilium. The 3D visualization system, and we choose the right strategy, and we choose ipsilateral collateral channel, but the carousel microcatheter could be advanced further. And then we use reverse cut and rendezvous technique, the integrated. Okay. So that this technique also very useful for the calcified lesion, and like in this case, because of time limitation, and that software I used in the MyStream 360 live demonstration, and won the prize in 1 week. And these are the techniques I invented in the last decade. So I think may be helpful for the routine PCI procedure. Thank you.